Good evening. I am Alex Morton. I'm in the graduate counseling program at Texas Wesleyan University, class of 2023. I'm supposed to graduate here in about 3 weeks, 2-3 weeks. This is a paper that I did for my advanced psychopharmacology, advanced psychopathology course with Dr. Michael Ellison in fall of 2022. My topic is called Stimulant-Induced Psychosis and Schizophrenia. It's comparative analysis between organic and inorganic manifestations of psychosis. And we'll get to that in just a second as to what qualifies each of those things. So schizophrenia and spectrum disorders. These are some basic symptoms that people can experience, and we'll go through here and kind of point out which ones are specific to which manifestation here. So the green is obviously schizophrenia in the spectrum. So we got hallucinations, paranoia, delusions, abnormal movements, absence of facial expressions, bizarre behavior, and lack of concentration. So those are very typical of the schizophrenia and the spectrum disorders. So which ones of these fall in line with stimulant-induced psychosis? We'll take a look. All right, you got bizarre behavior, abnormal movements, absence of facial expressions, hallucinations, paranoia, lack of concentration, and delusions. Wow, they're exactly the same. The interesting thing about this research project that I did was that when you look objectively at somebody who is in the throes of stimulant-induced psychosis or schizophrenia or anything on the schizophrenic spectrum, their manifestation of symptoms can be clinically indistinguishable when you look at them in an objective lens. If you had one patient in an observation room and one doctor and you had no details on how that person got there, what led them there, what their history is, you could come up with either of these diagnoses just by observing them and asking them a series of questions, which is insane. So what is stimulant-induced psychosis? So stimulant-induced psychotic disorder, that's SIPD, can occur from prolonged exposure to stimulant-class substances characterized by symptoms generally recognized in the DSM-5 as clinically psychotic, which include the symptoms we just reviewed on the previous slide, but it also includes suspiciousness, hallucinations, paranoia, delusions, impaired cognition, sensory motor capabilities, and distrust and unpredictable behavior, among many others. Stimulant, what is a stimulant? For the purposes of this research project, I went ahead and stuck with the main three strict stimulants as they fall in the DSM classification of controlled substances. We stuck with cocaine, methamphetamine, and common ADHD prescriptions, methylphenidate, which is Ritalin, dextroamphetamine, and the salt analogs, which are Adderall, and lisdexamfetamine, which is Vyvanse, which is a newer one. There's other less common substances, illicit and medical, like phencyclidine, psilocybin, some of the hallucinogens, common weight loss prescription medication, and even marijuana. All of these have clinical markers that could classify them as a stimulant under the ideal situation with, depending on how they're ingested, what the person's background is, age, gender, all those kinds of characteristics. So there's lots of different things that have stimulant properties, but for the purposes of this project, we have stuck with the main three: cocaine, methamphetamine, and the amphetamine and analog prescriptions. So those were considered inorganic. Those are extrinsic, outside the body. You take those inside your body and have a reaction for them. They are inorganic, extrinsic, you introduce them. Schizophrenia and the spectrum disorders are considered organic. They occur, they originate, and they run their course from within the body. There's nothing, you can't catch schizophrenia like a cold. You can't get cut and catch schizophrenia like any kind of disease or something like that. So the schizophrenia spectrum disorders, we've got the basic forms of schizophrenia. There's a subtype, catatonic schizophrenia, paranoid schizophrenia, residual, and then there's undifferentiated, which can fall in different categories. Schizoaffective disorder is schizophrenia paired with other personality type disorders like bipolar disorder, borderline personality disorder, things like that. There's delusional disorder, which is mainly obviously just delusions. And then the schizotypal, schizophreniform, and brief psychotic disorder and paraphrenia, Those have some different diagnostic criteria, but they still fall within the schizophrenia spectrum. Paraphrenia is a form of schizophrenia that develops later in life, almost like dementia. So as I wrote here on the bottom, there's many other disorders that have psychotic symptoms like dementia, manic phase bipolar type 1 and 2. The stress and anxiety disorders, obviously, if you get really, really stressed out, you can have some wacky psychotic symptoms, as well as sleep deprivation. That has been extensively studied, especially in the military. So the parameters of this study, just like with the medications, we confine those to those three subtypes, those three types of substances. For the schizophrenia spectrum, we have stuck with these, and we have eliminated any of the ones that have overlap with psychotic symptoms without existing on the schizophrenia spectrum. These, like I said, are considered organic. These originate in the body, run their course in the body, and there's nothing you can take to catch it. There's existing studies and precedents involved in this case study, in this project that I did. So in 2008, on the left, there's a 14-year-old female in the UK. She was given a therapeutic dose of methylphenidate, which is Ritalin, for ADHD symptoms. And a therapeutic dose means that it's the same dose that anybody might expect to take for ADHD. It's not like she was abusing it or anything like that. She was prescribed it by a doctor for ADHD symptoms. Within a couple of months, her mental state had deteriorated. She developed severe psychotic symptoms. She was afraid of people outside the home. She would check her locks all the time. She had a BB gun. She had knitting needles that she kept to defend herself against intruders. She was hearing voices, and she was seeing shadowy figures, and among other obsessive psychotic symptoms that she did. On the right, in 2014, they surveyed 120 patients in Romania who were inpatient in the hospital for schizophrenia-related issues in the psychiatric hospital, and they objectively measured their levels of worry and fear. They determined that 2/3 of the patients had delusions of persecution, which is where you believe people, entities, law enforcement are out to get you or to persecute you. And they all had pathological levels of worry and fear, which fall into the psychosis kind of thing. And then on the bottom, we have researchers in Spain. They administered the cocaine experience questionnaire survey to current and former cocaine users in a hospital and in an outpatient setting. And they determined that the incidence of cocaine-induced psychosis can occur in 86.5% of all cocaine users. So that means that of every single person who tries cocaine, there is a possibility of 86.5% of them developing some form of psychosis from their use of cocaine. That is a staggering statistic. The major difference between all of these is impermanence. So on the left, I go into kind of the schizophrenia. It is considered a brain-wasting disease. You are never healed from schizophrenia. Once you have that diagnosis, your brain actually shrinks by up to 25% by the time you pass away. Your brain literally wastes away and shrinks. You do not regenerate any of the brain tissue that you lose with schizophrenia, and then even dementia and some of the psychotic disorders. Those are incurable. Treatment for those is constituted and focused mostly on treatment of alleviating the symptoms. So you have hearing voices, delusions, shaking. Those are symptoms that are treated with psychiatric medications, among other things. But there's no cure for it. You treat the symptoms, and then you treat the caretakers for that. On the right, you see stimulant-induced psychotic disorder is treated with medication, rest, and hydration, and complete cessation of the stimulant almost always leads to total dissolution of the psychotic symptoms. So what we have here basically is the permanence is the major difference. If you stop using the stimulants and you detox and you get rest and you hydrate, for the most part, the symptoms will disappear. Schizophrenia never gets better. So these things can be clinically indistinguishable in a clinical setting. And if you elongate that and you treat the person with the schizophrenia spectrum disorders will never recover and get better. They can have periods of plateaus and symptoms, but their brain will never heal. And that's where the difference between these comes, because if you're taking any of the cocaine, amphetamine, or methamphetamine, there is on the bottom, I wrote post-acute withdrawal syndrome that's being studied extensively these days, where you can have kind of post-traumatic stress responses to triggers and things like that can make you have relapses and some psychotic symptoms, but they're short-lived and they're transient, and they end up terminating after a period of time to where you will actually usually fully recover from stimulant-induced psychosis. Here's my sources. And as I said, I compiled all of this research and information from my class on advanced psychopathology with Dr. Michael Ellison, of which I wrote a paper for. That's my presentation. Any questions? All right, awesome, thank you.
Thank you.